All
Good
right.
morning.
Hi, good morning. You guys look great. So today, I am Theresa Razzano from Alameda County, and let me have everybody introduce themselves. We're going to be presenting how to launch an IPS program. So yesterday we gave you data that supports the model and IPS 101, especially populations, how to develop a relationship with the Department of Rehab and what's important. And today we've talked about benefits this morning, and now we're going to teach you how to actually put together a program for your county, and then more, of course, later this afternoon. So first, let's have everybody introduce themselves. Who wants to go first?
I can go first. Good morning, everyone. I'm Roger Daniels, Senior Director at Finch Youth and Family Services, primarily working with community-based transition age youth programs, and those are the programs that have our IPS services attached. Did you want me to say a little bit more about how long we've been doing this, or is that?
In a minute, we'll get to that.
Great, thanks.
And good morning, everybody. My name is Betsy Knight, and I'm a Behavioral Health Program Coordinator with the County of San Diego's Behavioral Health Services. And one of the multitude of things that we do in our county is to have contracted services, and we have the IPS model infused throughout each of our levels of care, and that is one of the fun tasks I get to oversee.
Well, and Betsy and Roger and I are presenting this session to you because we are the veterans, in the state of California. I think that our programs and counties have been utilizing individual placement support longer than anybody else in the state. To fidelity, okay? And so what that means is that an evidence-based practice requires measurement. It's not an evidence-based practice unless you measure it against your fidelity standards. And so all of our services have annual fidelity reviews, to make sure that we're meeting the objectives of individual placement support. And it's a simple recipe, right? If you are meeting the standards and following the recipe, that means your outcomes are great. And so we'll hear a little bit more about that in a minute. So I would love it if both of you would tell us a little bit about your programs and services, the populations that you serve, and how long you've been doing this.
So the populations we work with are transition age youth between 16, 17, and 25. Our programs are community-based, although one of the programs where we have IPS is a transitional housing program for former foster youth. We've been doing IPS for a while. I actually was pulling together my notes this morning. I was like, wow. So we were awarded funding for the Alameda County pilot back in 2012. We started the program in early 2013, and then we expanded IPS to 3 additional programs in 2016. And then in 2019, we expanded county-wise in terms of starting a pilot in Santa Clara County. Most of our programs have the employment specialist embedded with a mental health team. Although our Santa Clara program, we're embedded with a mental health team, but it's not our mental health team. We partnered with Momentum for Health to provide the employment services to their transition age youth.
Great. How about you, Betsy?
In San Diego County, we have the IP, well, we've had supported employment since the early 90s. So that's been the wonderful part. But we didn't infuse the IPS model until we went up to Alameda County and learned a bunch about it and decided this is definitely the route we want to go. So in fiscal year 18-19, we implemented the IPS model and have taking strategies to address consistency across levels of care, because we do have employment specialists infused in our contracted programs through the assertive community treatment, our outpatient mental health programs, biopsychosocial rehabilitation centers, as well as clubhouses. And then we have two programs that I call employment only, because one is a cooperative agreement with Department of Rehabilitation, and the other is called Employment Solutions, and it is an employment program that's, I want to say, is sort of like the overflow for when the clinics or the other programs don't either have too many people or the individual doesn't want their treatment and employment connected at the same site. They can go to this alternative program.
Nice, very nice. And so just to give you guys too, with Alameda County, we developed a partnership with the international learning community and were accepted as a member of that community back in 2012. And by acceptance of that invitation, we were given funds to be able to leverage other partners doing IPS. And so Fred Finch was one of the first ones to raise their hand and be an early adopter, and Bay Area Community Services was another organization that was an early adopter to that, and both received that contract. So then we had three programs, is basically was the launch. We had BACS, Fred Finch, and then the vocational program with that's embedded in the adult system of care. Currently, we have 18 county operated programs that the vocational unit is integrated with or embedded with. Those programs range from all of children's services teams to adult teams to our conditional release program to a collaborative program with a primary care clinic, trust clinic in downtown Oakland. We just launched supported housing actually during the pandemic. And we're looking to hopefully expand to the SUD system of care in the next year or so. We also have a training and technical assistance unit, which I think is important because for all of our programs, fidelity reviewing is really a part of what makes it work. It's one thing to come to a conference and learn a bunch and go, oh, wow, that was really great. It's another thing to how do you integrate what you've learned over time? And, we're all busy people. And so having fidelity reviewing, such as Chris Lorente is our IPS trainer, Santa Clara County, has Lynn as an IPS trainer. Betsy and Tom Stuberud in San Diego have been IPS trainers. So, the trainers are what keep the message going and help give kind of quality review information, which is what helps us, just sort of recalibrate, right? So that we can try to get those better outcomes year after year. So now let me ask all of both of you, what do you think have been the top considerations in launching your programs? I mean, what did you need to have in place in order to make this work?
I mean, I think there were probably three primary things. One was really looking at our existing mix of programs. In our TAE program, well, we have a couple TAE full service partnerships that are built on the assertive community treatment model. So kind of like what Betsy was saying, we already had supported employment and education as part of the service mix. And so IPS just seemed like a great way to carve out employment to both focus on that with our participants, but also to take a little bit of the burden off the other team members who were holding everything. So employment, education, individual treatment, just your typical model. And so IPS just seemed like a really, really good fit. I think, the other piece was really educating staff and, leadership about the IPS principles. And I just wanted to say to Theresa's point about the fidelity review, I really think that organizationally, IPS took hold after we had our initial baseline review. I think everybody wanted the model, liked the model, thought it was great. Yeah. And then you put it in place, you practice, questions come up, But when we had that baseline review, that really helped kind of focus on like, oh, this is what it means to, have executive leadership, for example, aware of what we're doing in terms of IPS. So the other thing I would say is infrastructure was really key too, in terms of looking at, okay, how do we, set up our progress notes? How do we set up our QA process? How do we set up our data collection process so that we can not only give data, back to the IPS developers, but also so that we could use it as a tool internally to do some of that education, to demonstrate for, clinicians, for example, that, hey, this actually works. We actually do get people employed, regardless of what is going on with them in terms of their mental health. And so those were, some of the things, looking at the existing service mix, doing a lot of education, like across the board about IPS and how it works, and then building the infrastructure to support the data collection and the QA piece.
Thank you. Betsy, how about you?
Absolutely important items. So thank you, Roger, for mentioning those. There are so many things that are important, I think, about considering whether to infuse IPS or not into your system of care. And one of the, I think, most important aspects that San Diego had is that we had a 5-year strategic plan. And our 5-year strategic plan said, we need to find something to implement. And by the way, you might want to consider this, evidence-based best practice called IPS. And so that was one of the reasons why we explored the IPS model to begin with. So having an understanding and awareness of it, having the strategic plan. And then at that time, also, we had employment specialists infused throughout our system of care. And they were eagerly asking, we want to be able to be on the same page. We want to be all doing the same thing, especially when we have mutual clients sometimes that need our combined and collaborative approach. So employment specialists were wanting to have the structure and the forms and the, I want to say, the support to be able to perform in their roles in an effective way. So we needed to do that. And because we have everything across different levels of care, clubhouses operate very differently from an ACT program, but yet this is the one thing that we can have in common. So having, again, this common theme amongst all the different levels of care, I think, made a huge difference.
Nice, very nice.
Hey, Theresa, I also just wanted to add too, one of the things that I think was really helpful was from the beginning, back in 2012, when we were looking at the RFP and, thinking about this service, the regional vice president was actively a part of that process. And I say that because I think one of the things that's important and that I really like about IPS is the kind of expectation of the involvement of executive leadership. And that also plays a key role, I think, in how successful the IPS program will be. So that, I guess, the long and short of that is the earlier you can get, leadership involved and on board, I think it just increases the likelihood that it's going to be successful.
Yeah, that's a really good point. So I created a little slide here for us. Let me see if I can figure out how to go full screen. There we go. Which just sort of, I think, piggybacks on what Roger and Betsy have already said. So, of course, one of the biggest things I think is you have to do consensus building, right? I mean, and both of you refer to that, is that, it's if you launch a program without doing this part, I can pretty much guarantee it's not going to succeed, because there's too many people involved in order to make it work. You need to get mental health providers to the table, that means executives, finance people, clinical directors, anybody where this model is going to touch or the funding is going to support, they have a stake in what the program is about. The local Department of Rehab, you should have whoever, as we said yesterday, Department of Rehab is, the third leg to the stool, right? You have to have the Department of Rehab at the table as well. They need to understand how their DR counselors are going to need to interact and engage with IPS programs to support them, because, you know, the IPS model is a rapid employment model, a rapid job development model, and the Department of Rehab is a huge bureaucracy. And so we have to tap into their expedited enrollment, to really work it, in order to make sure that our clients get open quickly. And of course, whoever's doing the actual direct service, right? And so, excuse me, for Fred Finch, you guys, I never realized how big Fred Finch is. You guys are all over, right? Are you only in the state of California, or are you beyond the state?
No, only in the state of California, northern and southern being mainly San Diego.
Right. Okay. And of course, San Diego is what, the second largest county, I think, in the state to LA or something. I mean, you guys are huge. And so, it's a little bit different, right? At Fred Finch, you have staff at Fred Finch that are providing the service directly to Fred Finch clients, right? Right. And then with Betsy, you have all these different programs, and you have employment specialists that are embedded in each program, right?
Yep.
Okay. And you have like 40 different programs, right?
40 plus, yes.
Right, right. So in Alameda County, we have a mental health unit essentially, and we are the service providers for our mental health system. So it's interesting because it's almost like a hybrid between the two of you guys, right? So everybody should be at that table, when doing the initial list. What about this model? What's it all about? And that some of the things that we've taught you guys yesterday, like some of the data sharing, for example, or IPS 101, are the things that you would want to share, with that consensus building group. You're building interest and enthusiasm, you're posing questions, and you're looking for early adopters, because early adopters are the ones that get excited about it, and they're the ones, like these guys are both early adopters, Fred Finch and San Diego, and Solano. I have to give a shout out for Solano as well, because they just, were curious and interested and rolled up their sleeves and just started, looking at what this was all about and looking for ways to make it happen. The next thing, of course, is securing funding. And we'll talk more about this in a minute. But essentially, IPS programs can be served or supported by Mental Health Services Act dollars, and most of us here should understand that, the Mental Health Services Act dollars are by regulation to support evidence-based practices related to housing and employment. Okay, it's housing, employment, and recovery supports. And so IPS fits beautifully into any program that is funded through MSHA, full service partnerships, other community-based services and supports. So that just works. With Medi-Cal, a lot of organizations and counties don't realize that at least 30% of the time of an employment specialist is billable to Medi-Cal, especially now under Cal-AIM, right? I mean, now we have Z codes, yay, and we employment specialists no longer have to pretend they're not employment specialists. They can actually write a progress note and said, I had a client coming in to write a resume today, and they had a panic attack. So we addressed their anxiety and talked about, what their interests and motivations are about work to get them refocused and excited. And then, of course, our Department of Rehab. So some counties have mental health co-op contracts. Other counties have fee-for-service. Regardless, that's another revenue source, to help this kind of braided funding approach. So let me ask you guys, while we're on the funding piece here, is, how has funding worked for you? I mean, Roger, I know that you have a contract with Alameda County, but you've also branched out to 2 other counties. So how else are you finding ways of funding and sustaining your program?
Well, I think, yeah, primarily it's been through the contracting process. We also, our full service partnerships, especially, are blended funding. So we've got MHSA and Medi-Cal dollars. The other piece, though, and this is also part of, I think, what Theresa was saying regarding consensus building, is involving our development department. So one of the things that's been really helpful, given the nature of IPS and the data that we collect, is being able to go for grants and funding from other sources to kind of augment and support what we're doing in our respective programs. But it's mainly been Medi-Cal and MHSA funding.
Betsy, how about you? How is it similar or different for San Diego?
Very much the same. Majority of programs are funded through MHSA with Medi-Cal dollars for those treatment programs that are short-term Medi-Cal approved. Definitely want to encourage all employment specialists to bill as much as possible as applicable. And yes, CalAIM is going to make a huge difference, making it just a little easier to be able to do that. But we do understand that the position of an employment specialist, at least half of it, is probably not going to be related to specific client services, such as the job development piece. Not going to be client specific. Sometimes it is, but most of the time not. So we do allow for some flexibility with that. And then our Department of Rehabilitation cooperative agreement is funded through realignment dollars, those valuable coveted dollars that don't have restrictions, which is very nice, but it also allows us to have some potential duplication of services, but it's more of a supportive way, so that if somebody is working with the DOR program, they can also work with an employment specialist who is MHSA funded, and we're not duplicating any funding issues. But sometimes there are clients who are in ACT levels of care who might need two employment specialists supporting them to move through their recovery and attain employment. So we have some flexibility with that. And then we also, through our technical assistance program, they are funded through MHSA dollars as well. And that, I think, is very helpful, especially because one of the things we do ask them to do as technical consultants is to find additional dollars for us. So the county's not doing it directly, but it's through that technical assistance that we seek additional dollars or anything that can leverage our existing resources.
So now you mentioned something I think it's important for us to kind of drill down a little bit, which is that employment specialists, whether they're working for the funded community-based organization or for the county, there's only certain things that they can bill to Medi-Cal, and the rest you have to find alternate ways of billing. Can you guys speak to that? I think it's important to kind of underscore that point.
Right, and San Diego, just to tap into that, if it's not billable through Medi-Cal, then MHSA funding does cover it. So okay. It's covered.
Yeah, and it's the same thing for us. I will say, though, that I think, in terms of, building an IPS program, the training piece is also really important, because not only is it about training the employment specialists to write to Medi-Cal standards when they're billing for employment services, and understanding like the nuances of how to do that, which, are a little less so now that we have CalAIM, but, there still needs to be some sort of connection there between, the mental health piece and employment and all of that. But the other piece is training, the clinicians around making sure that they're creating, the clinical reports that will support the progress notes that the employment specialist is writing. So that's, I think, something else that's really important too, because it also just has this way of bringing, again, this idea of consensus building to the teams, right? Because everybody had a little part to play in terms of the employment services piece.
That's a really good point. And again, I'm going to go back to CalAIM now that we don't have to do treatment plans. Woohoo! But we still have to do, we still have to do assessments, right? I mean, so people come in, they should have an initial assessment, and that assessment should include some language related to, do you want to get a job? Would you like help in going to school? And it's kind of a future, framed question. You could go into more about employment or education, but it's really just making sure that it is in your assessment, and that if a client is asked, then more often than not, they'll say, well, I've always thought about, getting a job, and that then immediately becomes, the trigger point, right, to refer clients out to whoever's doing the employment services piece. Because, I think for a lot of our clients, once they have some stability in medication, and even if, we've worked with people who are actively hearing voices and they are still able to go to work. Okay, so if they're motivated to work and they're linked, then it's, it's got to be in that assessment somewhere. So then your employment providers can use those Z codes in their progress notes anytime that they are working with the client directly and there's a behavior that is coming up that needs to be addressed. So in any kind of addressing or reduction of that behavior is billable time under Medi-Cal. Under Cal-AIM, under Medi-Cal. Now, as I mentioned earlier, employment specialists can actually say, I'm an employment specialist, which is great news. So we don't have to dance around what the work that we're doing. But the things that are not billable are or at least what I share with my staff is if you are sitting down and you're cranking out a resume for a client and they're not in front of you, and you're out marketing and doing job development and engaging with employers, that is absolutely not billable to Medi-Cal. There is no mental health intervention there. Right. And so that makes it really clean, I think, and Mental Health Services Act does cover that. Right. They cover education and employment supports, and Department of Rehab also covers that. So I think what we do is, you identify as an organization different coding, right? That, the Medi-Cal codes are already pretty concrete, but then Mental Health Services Act codes and a DR code so that you can make distinctions. This client is a Department of Rehab client. And so that is coded to Department of Rehab, and then all of those non-mental health types of things that are activity that is done can be billed directly to that code for the State Department of Rehab, versus if it's, a Mental Health Services Act, usually it's a client who's not open to a co-op contract or, is not, doesn't have any open case with the state DR. So anyway, it's just good for I think people to know that it's not that hard, I guess, to put that billing structure together for your direct service staff. But I agree with Roger that that's why you have to, when you get, after you get everybody for the leadership consensus building, the drill down is where the rubber meets the road in your direct service units, and how clinicians understand how to incorporate employment and education into their assessments, and that your direct service employment staff know how to write progress notes that are clean, based on what kinds of services that they're providing. So let's go ahead and move on to training, because that's been mentioned a lot. I think as it was said here, we want to get everybody on board: executives, clinical directors, employment staff, and Department of Rehab. And there's lots of different ways to do training. So why don't you guys first chime in on what your approach was to get your organization up and running?
Well, for us, I mean, we already had an infrastructure for training folks on writing the Medi-Cal standards, just since we're primarily, behavioral health, Medi-Cal funded agency. And so it was really a matter of looking at, okay, how do we integrate, writing to employment services, and then getting that included in the overall progress note training that we provided for new staff. I think within the program, once we got our contract, there were a lot of mini trainings with the team that were all really centered on the principles of IPS and kind of walking people through what that means and what that looks like in terms of practice, and really, really focusing on the I always want to say zero tolerance, but that's not. It's the zero exclusion.
Zero exclusion.
Really focusing on that, because that was one of the biggest things that we, experienced as a challenge in terms of moving people out of this mindset of oh, well, so-and-so, they have their co-occurring disorders, some treated, some untreated, we don't think they're ready for employment yet, or we think they should do X, Y, and Z before we move them to employment. And really hammering on that principle of that's not IPS. That's not how that works. When they come in, if they say, I want to work, our job is to figure out how to facilitate that. But you need the entire team to be on board with that. Because if you have an employment specialist who's giving that message, but you have a clinician who maybe is ambivalent, and you have a med provider who's like, nah, you can't work until you get on your meds, the participant's just gonna be very confused and less likely to engage. So I think that training piece within the program was, really critical. And we also did some things around, once we onboarded an employment specialist, and this was definitely with the support of the county trainers, Jackie and Chris, doing some job development mentoring, going out with these new employment specialists and kind of mentoring them through the process of job development, because a lot of the folks that we hired, I think, often had skills in their individual direct service work in terms of sitting with a participant, helping them with applications, resumes, all of that. But the job development piece and the employment or the employer kind of relationship building was something that was, new in many ways. And so that mentorship was actually really helpful. And then the last thing I'll say about the training piece was just taking advantage of the trainings offered through IPS Works, and both for the IPS supervisor and for the employment specialist. Those trainings were really helpful. After someone had been doing the work for a few months and kind of had a base knowledge, then having them do the online courses to just kind of reinforce and continue to build their knowledge was also something that I think was key.
I just want to mention too, that I think that structure that you talked about is another sustainability point, right? That, when you do that ongoing training, you are helping your program grow deeper roots, because it becomes an organizational philosophy instead of just the program du jour, to the staff. It becomes a part of the backbone. Betsy, what else can you contribute on training?
I can't emphasize how important it is. I think Roger definitely nailed a lot of the essential pieces, and there's always more opportunities for growth and for training. I think one of the areas that I think was most important is that we did through our technical assistance providers, they set up trainings and set up components I think they have 4 trainings each year based on what the system of care is asking for additional information. Also having we had quarterly, what was it called? The Individualized Placement and Support, the IPS Advisory Committee, which included the program managers. So we had the program managers, and then we also had a separate quarterly meeting with the employment specialists. Now we've got it merged together, so everybody's hearing the same information at the same time. So I think that helps to make sure that program managers are included in training and getting information as well. A lot of the agencies are starting to get lead IPS trainers, so that there is somebody within the agency, whether they've got an ACT program, clubhouse, outpatient clinic, or employment program, everybody is getting that same information within the agency. So that's helpful. I think also ensuring that employment specialists should be eligible to take trainings just like any other position, such as, motivational interviewing training or stages of change training, including, the mental health first aid. Our technical assistance provider had mental health first aid come in through our local trainers to come in and train all of our staff, so that the employment specialists have a common language and understanding of what mental health issues are and the impact of mental health issues on employment. So can never get enough staff training. And then Department of Rehabilitation about 2 years ago started joining in some of the trainings that were being offered by our technical assistance providers. And I think that has lended to DOR jumping on board to become part of the IPS movement in San Diego.
Yeah, that's nice. I love that. You know, it occurs to me too that by having all those new trainers sprout up in San Diego, I mean, the benefit to that is when it gets to the fidelity review, it's kind of a regular practice that if you have a home-based IPS trainer, that they partner with an outside trainer, right? And then you have that objectivity. And so it's usually the outside trainer that comes in and actually writes the report and you know, shares, you know, the various meetings and groups or whatnot and observations that need to be done. So that's brilliant because now you'll have many different IPS trainers that can partner with each other. That saves the organization money in the long run as well. I mean, we're so happy that Santa Clara County, you know, right next door to us here, you know, actually has an IPS trainer because now instead of going to our partners up in Oregon, you know, we can just, you know, call Lynn, you know, can you help us out with a fidelity review, which is a lot easier on so many different levels to make sure that that happens. The other thing I want to mention that you guys, something that occurs to me too is that helps with the training is that when you have an organization where employment services specialists you know, are new as a position that are embedded in clinical teams and yet supervised by a clinical director, that a lot of times clinical directors, it's a bit of a head scratcher on, you know, what do you look for productivity in an employment specialist? I mean, they know how to supervise clinicians, you know, but an employment specialist is a different animal. Have either of you found that to be true?
Yes and no. I mean, the thing that I love about IPS is that, you know, if you use a fidelity scale as like a program development tool and a supervisory tool, it can be really helpful. So what I mean by that is, you know, helping the supervisor understand, for example, that there's a certain percentage of time that that employment specialist should be spending in the community doing job related activities. And so in your supervision with them, you can have them pull out their calendar and you can go through the calendar together and see, you know, are you spending most of your time doing employment services or not? And if not, maybe that's a performance improvement issue or maybe it's a training issue. But point is you get that information. Same thing with job development in terms of having very concrete, this is the number of job development contacts you're supposed to have per week. Again, if you look at the calendar or you have a log that you use for the employment specialist to track their employer contacts, you can see pretty concretely, you know, is that happening or not? And so I think the whole idea of outcome-based supervision that IPS really promotes is really helpful in giving a template to the supervisor, even if they're wearing multiple hats. So they may be the clinical supervisor and the IPS supervisor. Ideally, you have an IPS supervisor, period. But, you know, in the instance where it's a combination, I think that template of outcome-based supervision makes it a lot easier, especially if you've got that other piece in place with regard to like training. So it's not just like, oh, here's this, you know, model of supervision or template for supervision, but you also understand what's behind it in terms of fidelity and the IPS principles and all of that.
How about you,
Absolutely.
Betsy?
I was going to
Yeah.
say, I completely agree with that. And then also the concept of having, and this is one of the things that we've, I want to say, put the responsibility also on the employment specialist to be the educator to their program manager on how to train. And then we're, of course, supporting the program manager as well as the employment specialist. But in statements of work for our contracted providers, we specifically detail that every staff and every employee at a program is required to be trained on it. Now, we don't say what that training involves, but usually it's being brought up on as an agenda item in a staff meeting so that everybody's getting some type of, you know, 10 minutes here, 10 minutes there, just reminders of how important and valued the employment process is in recovery. Because, you know, while I am a clinician, I do also strongly believe that the recovery of somebody is more focused on employment and other issues, not just medications and therapy.
And that made me think of something else too, and a lot of what we did when we started the pilot in Alameda County was constantly going over like role clarity and expectations. Because having an employment specialist embedded on an ACT team definitely fits with the model. It's definitely ideal to have that carved out, but it takes time for the team to understand that that person is really focused on employment. So unlike the other team members who, they might do a little housing, they might do a little supported education, they might, it's kind of like everybody's doing a little bit of everything. The employment specialist really needs to focus on employment. And so making sure that people understood that in terms of their role and their expectations of that person was also, I think, really, really critical, and relates back to the supervision, because in supervision, one of the things that the supervisor is doing is making sure that, the employment specialist is able to do their job and able to work collaboratively with the mental health team. And if there's anything coming up around that, then strategizing about how to deal with it.
Yeah, these are really great points. I really love the fact that, yes, IPS has all those kind of built-in supervisory tools, and that that a supervisor that is a clinical director or manager, has those to rely on. I think that's really important. And I think we should probably say too that for programs that launch, I mean, all of us have fairly large or substantial IPS programs, but when you launch a program, usually you identify a supervisor, and part of their time, could be 15% or whatever, is dedicated to reviewing the work of IPS staff, right? And so it doesn't start with a dedicated supervisor oftentimes, unless you over time build up a cadre of programs, and you have a reason for it. Our unit has 9 employment specialists. We have 1 dedicated employment specialist supervisor, but took us years to get there. 10 years to be exact. The other thing too is ideally with most IPS programs that that by fidelity standards, they like to see at least 2 employment specialists. And I like what was said too about making sure that there's a carve out for what the employment specialist does. Because one of the things that we saw with some of our local community-based organizations that have IPS incorporated is during the pandemic, there was a lot of IPS employment specialist poaching going on because everybody, had mandated mental health services by contract they had to provide. And people were moving around and leaving their organizations, leaving, this void. And so employment specialists were oftentimes utilized to do case management services. So we're starting to see that, those positions are getting reestablished again now, but I think there's something to be said about carving those positions out and protecting them. How did your programs fare during the pandemic, by the way?
I mean, I think all things considered, they did okay. It was interesting to look at, for example, the level of acuity of the population served, because our Santa Clara program works with a broader range in terms of mild, moderate, and severe versus our full service partnerships, which are pretty much severe. So for the, Alameda County programs, a lot of the contact during the pandemic especially continued to be in person. I mean, we have all kinds of safety protocols in place, but for that population, trying to do things virtually just was not working, including, employment services. Whereas in Santa Clara, I think we were able to do more with like virtual meetings. Every time I say that, I think about the employment supervisor, relaying a story about being on, I think it wasn't Zoom, it was whatever Apple, what's the Apple's FaceTime.
Oh, FaceTime.
being on FaceTime with a participant as they were going to an interview and coaching them, you know, that way as they were going into the interview. And then the ability to use technology was a little easier because the level of acuity isn't as, significant for some of those participants. But it was definitely, challenging in terms of the engagement piece and the, consistent contact. And, for a while there, job development was really difficult because everything was closed. And so anyway, those were some of the challenges, that we faced.
And I was a little surprised at how good it went. Because amazingly enough, I would still see success stories and things are working well, and it hasn't stopped some people, but then it stopped some others of, I'm not sure I want that type of job. I want a different type of job. And amazingly enough, some people have really sought out jobs where they're working remotely and not working in groups. So it's been, I think, successful overall. But really sort of an interesting process that we were forced into. And everybody just stepped up to things. I think one thing that was really nice about San Diego County is our technical assistant at the time, he started a job developer forum. And so it was the employment specialist meeting every week at the same time to discuss strategies and how they're working with people so that they could support each other and find different ways to be more effective in the environment. And I think that really helped to the extent that we don't have to have that as a weekly event anymore, but it's, I think it was really neat to see everybody stepping up and finding out how to make things work.
Yeah, I totally agree with you. I know here, we are mental health. We're all essential services workers, right? So nobody was off. We all had to work still. So, I told my employment specialist staff, and my employment staff, here's the mask, here's some what do you call it, the stuff that we put on our hands, the antiseptic stuff that stinks so bad. Yeah. And mental health, our teams, we're putting plastic in the county cars between the front and the back seat. And we had standing wipes. We did everything we could to create a healthy and safe environment. And we continue to serve the clients who wanted to work. Of course, we honored the folks that said, this is too risky, or I don't want to, risk getting my family or board and care sick, that kind of thing. But everyone else, we continue to work with, and those clients got jobs as essential services workers. They were working in grocery stores or, other types of environments where, the services were on demand during the pandemic. And, and the other thing I remember in that beginning in 2020 is that we had a lot of employers that we had engaged with that hadn't really nailed down their safety protocols. And so our staff was the one doing it with the employer. Are you supporting, social distancing? Do you have masks for everybody who works here? Or do you have hand sanitizer, and are you, putting up barriers? I mean, we were out there, kind of teaching some employers, to get their house in order so that they could not only continue their work, but we could make sure our clients were safe, and through all of that, our job placement rate actually increased, in 2020, about 12%. And I think we had maybe one client that caught COVID, and it wasn't from work. It was from their living arrangements. So if anything, we had to go back, the employer was, eager to get them back to work. So we, had to advocate and, with the living provider, the boarding care, to be able to get that person working again. So it was interesting. So I just want to, I'm glad that we could have this conversation, because I want people to know that even with the ebb and flow of the pandemic, such as it is at this point, that this model is still working, and that clients still want to work, and that working for some clients is better than medication. I can't tell you how many depressed people have just done a 180, and how their presentation is by just getting a job. To having that sense of excitement and obligation and mastery, that they get to have every day versus sitting home, worrying about their depression. So let me move on here with this slide a little bit that you, Roger had mentioned IPS Works as a good resource for training. IPS Works, again, is sort of the hub of the international IPS learning community. It's now at Westat where Dr. Bond, and Bob Drake, the principal research team are embedded in Westat, which is a research organization. But the rest of the team now is split off to Columbia University. And they control the ipsworks.org site and have IPS trainers, and they have online trainings for new staff, online trainings for IPS supervisors. And I think they even have one for DR counselors too, don't they?
I'm not sure if they have one for DR counselors, but I do. One of my managers mentioned that now there's an online training for basically folks who aren't employment specialists, but have IPS as part of their programming to just give like a one-on-one kind of, this is what it is and how it works. And I know they also had a TAE certification
Oh, that's right.
process, yeah, as well.
That's right, because they just expanded their fidelity scale specific to transitional age youth.
Mm-hmm.
Right, because TAE obviously is a population that is tremendously benefits from this model. And IPS Works also has consultants, so if organizations want to launch a program and want to be able to hire a consultant, they do send out their trainers. Sandy Reese, launched all of ours here in California, of course, because she's from Oregon. There's also other local counties now, right, in the state of California. So there's a lot of programs and counties that have this technology under their belts, right? So we have two of them represented today with Alameda and San Diego, but Solano's been doing this for a really long time as well. San Francisco, their CalWorks program has been around for a really long time and have really good results and have achieved good levels of fidelity. And I think we heard yesterday in the specialty populations that they even had a couple of programs that had hit exemplary fidelity, and that's a unicorn. I don't know of any locally. And Santa Clara County has just launched their IPS program in the last few years. I'm trying to think of what other counties, have done this to fidelity. So they're popping up, so keep your ears open for resources for people where you can partner with those counties. Just pick up a call and talk to your colleague. And then, of course, there's IPS consultants too, that we've been doing this for a while now. So we have some folks that are moonlighting and helping out, to launch or to consult or to do training. We've got some retired folks, I know one recent one from San Diego and others that are going to be retiring soon that are IPS specialists that have a lot of information about this technology. So there are resources out there. And of course, the most important thing would be to look at finding how you can develop an IPS trainer position to keep your services aligned with fidelity. I think, Betsy, you mentioned how you have all these IPS trainer positions popping up in all of your programs.
Yeah, and I think that's really neat to see them take on the leadership, and then I hope eventually we'll have our technical assistants have leadership and training also, so that we can really support the identified need that's out there. Because again, without the training, people just start to spin their wheels and then might get off on the wrong course. But we want to keep everybody aligned with the fidelity, which I think really leads to, again, the successful outcomes.
Excellent. So let's move on to the data piece. How did you guys put together that data capturing piece and say something about why it's important?
Well, when we started, we were working with Jackie, and I think there was a database that was recommended that we tried to implement with some degree of success, but there were some additional things we wanted to capture. So from there, we created more of an Excel-based workbook for capturing, information related to, enrollment dates, connected with DOR, benefits, just all these different things that we wanted to be able to track, along with job starts, so and job ends, so that we could, you know, collect the data for the developers, but also we could see, you know, trends in terms of where folks are working, where they are, you know, where folks are working, whether they've been working for, you know, 90 days or less or 90 days or more, just things that internally we wanted to track. And then we basically went from there to getting most of our IPS, well, actually, I think all of our IPS documents into our electronic health record system. And so what that has allowed us to do now is to pull, you know, different data from those forms that are being completed to generate reports that help us track things like competitive employment rate, enrollment, number of job starts, number of folks who started IPS during any, you know, particular quarter. And that's actually been really helpful, because now what it means is the employment specialist doesn't have to, you know, think about two different systems, right? They don't have to think about this one system over here where you're entering data, and then this other system over here where you're entering documentation. You just enter everything into the EHR, and then we can pull reports based on, you know, different categories or metrics or whatever in the reports that the employment specialist is doing. So that all, you know, especially on the EHR side, took a lot of, you know, effort in terms of building the forms and, you know, trying to make them as user-friendly as possible, so that, you know, it increased the likelihood that folks are going to actually do the forms in that system. But the data collection piece has been super important in terms of, you know, grant writing or grants, for example, and being able to have information readily available to give to the grant writer to pursue whatever grants we were trying to get, you know, where we were demonstrating, you know, the successes of the employment program. Theresa, did that capture?
Oh yeah, for sure.
Okay.
And absolutely, data is essential, because you can't prove anything unless, you know, you got the numbers to show it. And in San Diego, we worked really hard to not like recreate the wheel. And when we started with the Supported Employment Initiative back in 2014, we looked at, well, where do we currently track information now for data? And it's through the electronic health record. And it doesn't cover our clubhouses, but it covers the other components. So let's see where we're at. So we worked with the clinicians and any staff who are entering that data for, it's on our demographics form as to whether somebody is actively in competitive employment or whether they're actively seeking work. And then there's a couple of other things that, you know, are options in there, but those are the two things that we're really focusing on. And we were able to track from before we started the IPS, or before we started our supported employment model, we were at 9% of our system of care was competitively employed. And now, working through the IPS model, working through supported employment, the whole concept, as of our last data report, we're now up to 14%. And that's pretty darn cool. Almost every year was a full percent. Sometimes it wasn't a full percent of increase, but if nothing else, the numbers were continuing to increase. And I think that leads to the whole concept of getting some consistent information, everybody entering the information as accurately as possible and updating it when things change. That helps. And then the other part of our data component is tracking by program level. And we started off with an Excel spreadsheet that our providers would submit the same information each quarter. It would take somebody on my staff at least a month to review all the information. And then we would send it over to our technical assistance consultants, who would then clean it up and summarize the information. So in about 2 to 3 months, we'd have accurate data. But we've shifted this past year to our technical assistance subcontractor Corporation for Supportive Housing developed a database through Tableau, where we now have providers entering the information on the same date as they were for their status reports, but it's now going into the Tableau database. And then in a matter of 2 days, we are getting our results, and we can pull the information as to how many people are actively employed, how many are active job seekers are being worked with, and the length of employment that's somebody's that the programs are working with, how long people have been employed. So we can pull that information much quicker now. And it, I think, helps with seeing progress, and then we're tracking it across the levels of care for ACT programs, outpatient clinics, and then clubhouses, so that it gives us a different way to look at information. And then on the status reports, we're still tracking, we've actually just started tracking the actual employer. So our technical consultants can follow up with the employers that are hiring for multiple programs. Also trying to find out the different types of jobs somebody's working at and the rates of pay to ensure that they are, not everybody's working at McDonald's, not everybody's working at Costco or whatever it is. So we've got that diversity going on, and it's, I think it's been very helpful, and it just, for us, it gives data in a quicker manner so that when I'm trying to advocate for something, I got my numbers that are a little more updated.
Wow, I love that. You know, these are really important things to measure, right? To make sure that our programs are in alignment with fidelity. So I really love all the different ways that San Diego has come up with some resources to do that. And I wish there, I'll say it again, I said it earlier in the conference, is that, you know, what we need is a data hub for the state of California. You know, that if we could find a hub, whether, you know, in Sacramento or a community-based organization that is funded to do this for all of us, then the state of California could be a member of the IPS learning community and not just Alameda County. We really want the whole state to be able to reap the benefits of the resources of that learning community. It's just extraordinary. So I think we only have a few more minutes here. I wanted to mention here that again, developing and strengthening the local DR partnership is another important component, right, to be able to launch a successful program. Could you both kind of share briefly what your experience has been with the state?
I think for us, it's been a mixed bag, and a lot of it has been dependent upon either the supervisor we're working with or the DOR counselor or case manager that we're working with. I think, though, based on what we learned from that experience in Santa Clara, which is a newer IPS program, we actually worked with the county and with DOR down there to create a pilot in terms of having a formal structure in which IPS and DOR are working together. And I think that's been much more successful in terms of getting folks signed up with DOR and, you know, having a dedicated counselor who works with TAE, who understands IPS. And so it just makes things, you know, work much better in that regard. So.
And Betsy, we actually got to talk to Mahogany Harris yesterday from San Diego.
Okay, beautiful. Yeah, and San Diego has had a wonderful relationship with Department of Rehabilitation since 1995 when the cooperative agreement started, and it has been nothing but positive since then, especially with the implementation of IPS. They've required their staff to go to the IPS trainings when, well, it was pre-pandemic. They started going to the trainings and have done nothing but really look at how they can, amazingly enough, shift their policies, shift how they're doing things to really get people connected up with employment specialists in a more timely manner, and how they can support the IPS model within their structure as well. So it's been very positive. So I would encourage everybody to, if you're having challenges with your DOR cooperative, then look to San Diego County. We'll get you connected up with the right people who have been very successful at helping implement it here.
Awesome.
Yeah, I would say where it's been really, where it's worked really well, it's been super successful in terms of being able to augment, you know, what our participants needed in terms of resources that, for one reason or another, the program couldn't provide. So when it works, it's a beautiful thing. It's like bringing everything to bear in terms of helping those participants get jobs.
Right. So it's worth the invested time to create a better partnership, because our clients only benefit from that resource and from that collaboration, right? So I wanted to read, let's see, we had a couple comments here. Kevin said that Solano had a huge uptick in job openings, which only positively impacted their clients. And Beth said that both the trainings are on the IPS website. So I think related to employment specialists and IPS supervisors. And I think there's one now too for the clinicians. I'm going to say case managers. I remember seeing something for that as well. All right. So in closing, what are your final tips and tricks, words of wisdom for any county, or mental health program that wants to launch an IPS program for their organization or community?
I guess the one tip I would have, which is going to sound like, duh, of course, but is really, when you're thinking about who you're hiring for the position, take some time to figure out, like, what kind of interview questions, what kind of process do we have? Because I think the employment specialist role, for all the reasons we've talked about thus far, is unique. But I jotted down, I was like, if I could find the person with the right mix of skills, what would that look like? And basically, someone who has mental health experience, sales and marketing experience, project management experience, the ability to work autonomously, but also to work as part of a team. That's like the unicorn, which you never find that. But point being, thinking about the position from that perspective, because where it can get complicated is when you're looking for an employment specialist through a mental health lens. So, and that's what people on the teams are comfortable with. That's typically what we're looking for. Do you have mental health experience? Have you worked with this population? But there's some aspects of being an employment specialist that I think are very different. For example, the job development, kind of the sales and marketing piece, that you're not necessarily going to capture if you're using the same interview process for your employment specialist that you use for everyone else on your team. So I would definitely say that, thinking about that in terms of your hiring practices would be really good.
Nice. I like that.
All right, and I strongly recommend that you get the buy-in from your leadership, because if it isn't happening up top, it ain't going to happen down lower. That's really important, and especially because they're the ones who are going to want to see the success stories. So if they can understand what it is that they're putting into it and how they're investing in it, whether it's staff time or contract dollars, whatever's being done, they want to see what the outcome is. And then, of course, always be patient with the process and how it gets implemented, to understand and think about when implementing the different components, always having the philosophy of how can we make this work? Because having that information can always be challenging, and it's a barrier, it's a problem, but no, it's not. And let's figure out how we can make things work. It just helps make a better program in the long run.
And I would add that persistence pays off, as well as strengths-based story sharing at every level. That, the more mental health teams hear that some of the clients that they've worked with for years are actually going to work, and hear the stories of how people are cleaning up for interviews and, taking jobs or getting promotions and getting raises and all of that, at every level of the organization, I think the more it kind of underscores that an excitement, that this, not only does the model work, but our clients are getting better. That it's a mental health intervention, and that we're seeing this dramatic result from it. And I always have said that the secondary gain for an organization is that the providers also get juiced. That they start to see clients that they've worked with for years do things that they never expected was going to happen. And it has a real dramatic impact on them, I think, and they start to then kind of kind of renew their passion, if you will. They become believers of recovery at a different level, and that has a dramatic impact on your whole organization, much less your IPS program. So anyway, I think that there's something to be said for strength-based communication and storytelling. All right, well, thank you. Oh, it looks like we have one last question here. Oh my goodness. And I know we're a few minutes over time, cutting into people's break here. Is that I think there was some confusion for our San Diego supervisors that this training was not only focused, was not county focused. Oh, I see. They were just saying that their supervisor, it would have been good if their supervisor had also been participating. And to educate supervisors when they have a different info and understanding. That's very true. Getting people involved, to be able to hear this information is important. And, but you know what, we're going to hopefully be able to launch this whole conference, or at least different segments on YouTube. And so there might be kind of an introductory way to invite supervisors and leaders in to hear certain segments that you think are relevant. So I would encourage that. Anyway, thank you guys. Betsy, Roger, you guys are amazing. I'm always impressed. It's just super fun actually to have this conversation with you guys. So thank you, everybody. Our next